Just by listening and understanding, providers are starting to see things through a different lens. That is one of the first steps in becoming a trauma-informed provider, is can I see it from someone else's perspective? And real quick, ended up in this space. I am an obstetric anesthesiologist, and so people ask me, how is it you're doing psychiatry or psychology work now? And it's, from the sounds of it, I'm doing a little bit of some chaplain type of work as well as an advocate and someone who supports. But I exclusively with obstetric patients, pregnant, postpartum, about 13 years ago. So that gave me an opportunity to be on the floor every single day, anesthesiologist in a high-risk center. So I could see trends over time. I could pay attention, and I was starting to notice things that I just couldn't understand them, behaviors, patterns. And it wasn't until someone referred to me a patient who had a history of PTSD because they said, you have a nice way with patients. Can you handle her? She's difficult. I didn't know anything about PTSD either at that time, but I was curious and I was willing to. Too many details about her. Taught me what it was like for someone to live with PTSD, have children, or be involved in things. One, she knew much more about her disease and her body than I did. A very competent mother of 2 other children, and we needed to establish trust in order to come up with a plan. Right? She also taught me some other things and sent me to become a sexual assault counselor, which I did about 7 years ago. And that is what really helped me to find some context for what I was seeing in labor and delivery. So not all the trauma that I was seeing came from sexual assault or sexual trauma. Trauma survivors, intimate partner survivors, similar. I had context. Did is I received a grant to develop a clinic. It was kind of my already existing high-risk OB anesthesia clinic for physical complications. Now I expanded this for more psychological complications, started training some more, getting some more skills myself. And now I run a very busy trauma-informed care clinic where I am, and I listen to 11 trauma narratives a week. I help with collaborative planning during pregnancies for someone who, and I help individuals in that first step after a validation, listening, and then determining where do they need to go for healing and post-traumatic growth. That is how I've ended up here. Before I really dig in, and I have a lot of material, so if anybody needs to stretch at some point, feel free to stand up, walk. When you talk about trauma, it can be really challenging, and some of the material might be distressing for some of you. Given the numbers of people in this room and by statistics, there are here today with your own histories of trauma of some type. If you're working in the obstetric space, I'm pretty sure you've experienced traumatic birth experiences as a provider. So I want to meet you where you are. That's part of being trauma-informed. Intersection of psychological trauma and childbirth. Disclosures, I am the owner of the Empowerment Equation. It's a website, an organization working for AI tools to help with recognition of maternal hemorrhage. Interestingly, that was our talk today. 2 companies do not preclude me in any way from giving you an unbiased presentation today about trauma-informed care. Learning objectives, although there are many more I could have added in here. This you'll learn what unresolved traumatic stress looks like in patients, family members, and in us. To recall what happens after a traumatic birth. We heard some of that today in Kelly's story, but there's also a lot more to that. What are the different interpersonal traumas that impact our patient population? The statistics I show you might be a little disconcerting. And then I'm going to introduce you to some basic trauma-informed care practices. This lecture is in no means a way of training you to be trauma-informed. Lecture, this is the start. I'm going to start with a simple vignette of one type of trauma. Newly minted sexual assault counselor, I understand trauma now, and I come on to our busy labor and delivery unit in the mornings. And there's a lot of chaos at the nurse's station. What has just happened is a person had been admitted about 4 or 5 in the morning from a midwife center, having her first baby, early labor, and by our standards, objective standards and measures, had preeclampsia with severe features. And she was sick and her baby was sick. But all of our great tools and interventions and medications were rendered useless on this patient because she said, no, I'm refusing everything, including a cesarean section, even though providers said, your baby could die. She said no. 2 questions when I walked on that unit. I said, 1, does this patient have any other history of illness? No. Remote history of abuse, almost in passing, or at all. That opened some doors. Why? Of everything, or why she's refusing? Or has anyone said, can you tell me more about this? No, no one had done that either. So in the meantime, they had already consulted the ethics committee, psychiatry, social work, and the legal team, which made me raise an eyebrow because I'm not sure what they were planning to do with the legal team. Like, my mind went to very dark places. Okay, so just think through some of the implications to this scenario. Of course, there's increased risk for morbidity and mortality, right? If we can't come to some collaborative agreement here, we know what happens with this. This patient could die, her baby could die, right? How about the cost? Look at how many resources and referrals they called in by 7 a.m. That's a lot of extra cost. Nobody wants to be in this next line with the gray. Who wants to be there? Is it mom's rights, baby's rights? Who's trumps who's, right? Staff, how frustrating it is, because we really want to be offering the best care and we know what's right from a medical perspective. Helpless, powerless, which are undertones of our own trauma when we can't do what we feel is the best. But then, one of the reasons we're here today is this last one, is that many providers have absolutely no idea how to recognize a psychological process as it's unfolding right in front of them, and let alone what to do with that. All right, we're going to come back to this vignette at the end if we have enough time. So we'll make time. Another type of trauma that I would like to, and I was hoping that my anesthesia colleague was here still. I don't know if he's still here. But this is something that we are seeing and recognizing more within the anesthesia community. This patient is taken for an elective cesarean delivery for a set of twins. She has a spinal, right? She has no other risk. She has no history of trauma. At incision, she tells her providers, I can feel that. She states it's hard to breathe. She feels like she's panicking. Her heart is not right. Providers treat her with thoroughly address the pain aspects, and they continue with the case. So postoperatively, she ends up with severe pain, and she feels like she's just in shock. What just happened to me? This surgery without appropriate anesthesia, and nobody listened. She felt dismissed, which is the other layer here that complicates her picture. She ultimately develops severe mental health complications and ends up in my clinic. So just trauma comes in many forms. Those are just 2. I could have spent the entire 75 minutes just with case vignettes, but I think these 2 will start us off. Okay. So what are we talking about with psychological trauma? It's not the same as physical tissue injury from a motor vehicle accident, right? In general terms, and I really like this quote by Judith Herman. I think she does a wonderful job. She's an expert. She studies rape survivors, domestic violence. But I want you to listen to some of these words as I read this. Psychological trauma is an affliction of the powerless. So powerlessness. At the moment of trauma, the victim is rendered helpless. Helplessness, powerlessness. When the force is that of nature, we speak of disasters. When it's that of other human beings, we speak of atrocity. Events overwhelm the ordinary systems of care that give people a sense of control and meaning. Okay? Control, connection, and meaning. That's what trauma takes from people. They're extraordinary not because they occur rarely, but because they overwhelm the ordinary adaptations we have to life. They confront humans with extremities, again, helplessness and terror. Okay, so powerlessness, terror, loss of control, connection, and meaning. These are themes that run through almost all the trauma narratives that I'm exposed to. Now, there are other definitions of trauma. Which is the diagnostic manual that the psychological community uses, defines it like this. An individual has to be exposed to death, threatened death, actual or threatened serious injury, but it doesn't have to be direct exposure only. It can be witnessing the event. We're witnessing a lot right now gun violence on our televisions. 9/11 was one where people had trauma from witnessing the event. It could be learning that it's your relative, close friend, unborn child. It could be indirect exposure, which is also called secondary trauma, vicarious trauma. This is our trauma. This is what we are experiencing probably weekly, if not even more frequently if you're working in obstetrics. And I'm so glad that the chaplain commented on the fact that we are traumatized as a group, and we need to learn how to recognize that and heal ourselves. Now, it has only been in the last probably 8 to 10 years that perinatal mental health specialists have included negative events in childbirth as meeting this diagnosis or meeting the criteria to be called a trauma. So think about that. Before that, we couldn't say that childbirth was traumatic based on this medical diagnostic manual. PTSD didn't even come on the scene until 1980. All that we know negative events surrounding childbirth can meet the criteria for trauma. How we can put things together for patients, we might be able to identify those who have that constellation of symptoms as not just having postpartum depression, but now having postpartum acute traumatic stress symptoms. Because the treatment is different. Okay? Someone mentioned it this morning, trauma is in the eyes of the beholder. Very, very important. We cannot tell someone that their experience was traumatic. Say that. We can certainly say they had a terrible complication, but the patient themselves has to be the one to say whether or not it was traumatic. I want to caution everyone in this room against trying to triage someone else's emotional experience based on how we think they should feel. And we heard some of that this morning already. You should feel happy. You have a healthy baby. Don't you feel so grateful? We saved your life yesterday. One of the things I've said in the past, and I cringe when I say it, is, you tried to die on us. Don't you feel so grateful? I mean, who was that for? It was for me, right? We did a good job, right? So just be cautious. Patients can feel grateful, and they usually do. They feel grateful. They are happy their baby's healthy. But that does not mean that they can't also feel all of those other negative emotions that were involved in getting them to this place. Another way to define trauma is to think about an individual experience or a collective experience. So individual traumas are self-explanatory. They're felt by the individual uniquely. This is everything from birth trauma, medical-based traumas, childhood traumas, sexual assault and rape, intimate partner violence. Community-based traumas are those collectively felt by large groups of individuals. We have several wars going on in our globe right now. I cannot even begin to imagine the levels of trauma, higher populations of people experiencing war. I just saw again this morning on the news some pictures of Asheville. I mean, where are those tissues? It really is overwhelming to think what that whole population is going through right now. Right? Racial-based traumas that are still going on have been going on in this country for 400 years, felt collectively. COVID was a trauma that we felt collectively as providers. And I would argue we're still going through that. Every person and every group has a unique experience of trauma. There are some commonalities that go through all of these, some common themes. You've heard these already. The feelings of helplessness, the need for control, the inability to trust others, safety, not just physical, but psychological safety. And then for those that have traumas early in their lifetime, as a child, for example, they often have a lowered sense of self, which means they have a hard time advocating for themselves. It's everywhere. And as I mentioned, it's a cultural change to start to be aware and change how we interact. Trauma has to be seen like that. Trauma awareness is a cultural change. One of my favorite, lines or quotes that I read is this one. Not trauma aware is trauma denied. So one, it says system, which means systems have to become trauma aware as well. But it means if we are not aware and acknowledging the presence of trauma and violence in someone's life, we're denying the existence and the influence it has on their behaviors later on. Right? Really important for us to recognize this. And yet another definition of trauma. Okay, this one comes from the Substance Abuse Mental Health Services Administration. I like this one a lot. I think it's a little bit more straightforward, simplistic, and covers a lot. 3 E's. You have to have an event or series of events experienced in an emotionally or physically harmful or life-threatening way that has lasting adverse effects on the patient's functioning, their psychological well-being, but it's also on their emotional, their social, physical well-being, and as we heard, a really great testimony this morning, to their spiritual well-being. Many times patients have shared with me that they have lost their connection to their faith after their trauma, and it's very important for us to try to reestablish that. So I want to walk everyone through just to give you an idea of what happens in the brain when we create memories. Do something very simplistic with a normal, non-threatening situation, and then we're going to imagine a threatening one so that you can understand how things start for our patients, either before they come to us or maybe what's happening in the moment when they're in our care. So you're all sitting here now. I hope that no one feels threatened at this to call on anybody, not going to put you on the spot. So hopefully your senses are just coming in and it's very calm. You're drinking coffee, have water, there's taste, there's smell, there's sounds. Gets funneled through the thalamus. Everything gets appropriately sent to different parts of the brain. And the amygdala is part of the brain that's involved with danger signaling. And again, this is a very simplistic slide. There are a lot more components to it. But the amygdala is important. If you've never had a bad experience in a lecture, you're probably still calm. You're sitting here. The amygdala isn't activated. So the information gets passed through the amygdala, goes through your hippocampus, gets a date and a time stamp to this memory right now, this morning. So when you look back 2 weeks from now, you'll be able to recall where you were, what you were listening to, what you were doing. From the hippocampus then goes to the prefrontal cortex to say what you're supposed to do right now in your seat and listen. Maybe nod your head once in a while, try to stay awake, those kinds of things. And then Broca's area will give you some words memory later on. Now, let's imagine that there is an explosion in the hallway. Okay, so the sounds are going to be different, and fire. We all know, we're trained from a young age, fire can be dangerous. So what happens in our brains now? And I also want you to think about perhaps what was going through Kelly's brain of her hemorrhage, right? Fear, different senses coming in. If it's a fire, you're smelling different things. But now your amygdala is activated. And unless you're a firefighter who's used to coming in, running into fires, you probably don't know a lot about what to do, and you're probably feeling fear or terror or anxiety. So your bodies and your brain primarily is producing stress hormones, epinephrine, norepinephrine, cortisol, vasopressin, endogenous opioids are being released. It's preservation of the organism, survival, freeze, and even fade out. When you think about dissociation, can be responses here. The information doesn't always get passed through to the hippocampus. Because you're in survival mode, it comes at a cost. So now you might not remember things on a timeline. Even through Kelly's story, she was a great example. She said, I don't have all the pieces to my story. And that may have nothing to do with medications or anemia. It was terror in that moment. Your brain is not allowing you to really lay down all the things in line. You might not get everything to the prefrontal cortex that you need, because you're going to look back and say, why didn't I get up? Why didn't I close the doors? Why didn't I do everything I'm supposed to on my badge? I have patients tell me, why didn't I run? Why didn't I scream? Why didn't I tell the provider I didn't want that? Why didn't I advocate? Guilt that comes from individuals who think they should have been able to do something different. But I try to tell them, your brain was doing everything it could to keep you alive and survival. And sometimes at the end, they don't have words, they just have emotions that go with traumas. This happens a lot with children when they have repeated trauma. They don't have words, they can't express what they're feeling, they have emotions. So what happens sometimes to individuals, extinguish this response, which is a normal response to fear. But when someone continues to have it, even when there's no threat, it becomes an issue. And over time, that can create a situation called chronic post-traumatic stress, illness, or syndrome. They're actually working to change the word syndrome out of that. So look for that in the next DSM-5 edition. Long-term psychological disruption because of the way that they process things. So, quick thing about PTSD. So this is what happens over time. They can get diagnosed with this disease process. So the traumatic moment needs to be there. They have to have at least one symptom in the next 4 categories. So re-experiencing is also called intrusion. This is where one can't stop thinking about it. It's nightmares. She was afraid to sleep because the moment she closed her eyes, she was back there again. Happened in the past. Okay. Avoidance and numbing. This can happen over time as well. Well, people just become very passive. They check out. They are isolated from their supports, perhaps, and they become the chips. They're people pleasers. They may also literally avoid care. They might avoid the operating room. Into this morning, hyperarousal. These are the symptoms of irritability. Can't concentrate. Can't sleep at night. Children after a birth trauma, the child, they can't stop watching the monitor. They won't leave the house. Paranoia, panic is there. Negative cognitions and mood. I'm going to say it's new anymore. It's been in this definition for at least 10 years, if not longer. Includes feelings of guilt, anger about the situation, blaming others, but it's also depressive symptoms. So I want you to think about that. We are screening a lot for depression, which is very, very important. But if we back up, I think sometimes we're missing symptoms are also included in post-traumatic stress, right? And I'm going to put a plug in for screening for both more regularly, because again, the treatments for trauma versus depression can be very different. And then the duration has to be at least a month to 3 months before it becomes a chronic situation, and it has to cause significant life impairment. So you can see it can be pretty difficult to meet everything for that diagnosis, but there are lots of individuals that come very close and are living with traumatic stress every day. Over time, they fall into what we call the trauma cycle, which is they have their trauma, whatever that is, or repeated series of events. They develop post-traumatic stress disorder, and then due to maybe an absence of good coping skills, no treatment, they become support to their faith. They become very vulnerable to what we call re-traumatization. And the most important thing I want to say here to you is that re-traumatization can and does frequently happen during childbirth, because childbirth is a monumental event in someone's life. And I just want to say, I think, and I'm very biased, but have the most important jobs if you're working in obstetrics. There is a lot happening from a hormonal, from a chemical, memory input perspective at the time of birth. So everything we do is incredibly important. But this happens a lot in childbirth. I think everyone needs just a minute about some education on the adverse childhood experience study, so that you understand what happens to individuals who experience childhood traumas. So what do adult survivors look like? What happens with chronic unresolved traumatic stress? I'd like to see a show of hands of those of you who've heard of the ACE. That's wonderful. When I first started teaching on this topic, I might see 2 hands go up. I think this is one of the most important studies that have come out in the last couple of decades, and yet I didn't even know about it until I trained as a sexual assault counselor. One of the biggest studies to date looking at this, over 17,000 participants in the Kaiser system, half female, half male, 3/4 had college education, everyone had a job. So I'm painting a certain demographic here, and even in this demographic, you're going to see how common these were. They looked at these 10 types of childhood maltreatment that had been identified in previous research. And I think the ones on the left, I think everyone can kind of think about those. If I said, think about child abuse, what comes to mind? Often the ones on the left. We don't often think about the ones on the right, though, but that's also included in childhood adversity in this study. ACEs were incredibly common. Over 50% had at least one. 28% of the participants reported severe physical violence as children. That's 1 in 4. 21% reported severe sexual violence as children. And there was a direct dose-response relationship between the number of ACEs, or adverse experiences, a child had, the number of these health risk behaviors in adult life. And there were more, but this is the top 10. You can see some patterns here. Substance use disorder, mental health issues, behavioral issues, right? These are things that our patients come in with on their chart. And I just wonder, how often do we see that and take a step back and think, I wonder what happened to this person that now they're presenting here with anxiety and depression at the age of 21, or they have substance use disorder, or they have a large combination of all of these. The magic number is 4, by the way, according to or more of these, to 12-fold increased risk to developing alcoholism and drug use as an adult, as well as suicide risk and depression. I'm coming to you from Pennsylvania. I'm in Pittsburgh. We did an expanded ACE study looking at different types of traumas. This was community-based traumas, where we're talking about violence, discrimination, foster care. They found something similar in the sense that Many of these individuals in all the counties around Philadelphia, adversity, right? 7 out of 10, and 2 out of 5 had experienced at least 4. So remember, 4 is the magic number. Think about all the health risk in that area of Philadelphia. When we look at the works of Judith Herman, who had that first quote that I put up, looking at rape survivors, Dr. van der Kolk is well known in his work. He's written the book, The Body Keeps the Score, if you've ever read that. And we have military medicine docs that are putting out some literature and data too, in addition to a lot of other research that's coming out, I would say almost monthly, looking at the physical manifestations of unresolved traumatic stress. But we see the same patterns. What does it look like? It looks like substance use disorder. It looks like mental health issues. It looks like behavioral issues, sleeping difficulties, and now all of these physical issues that we see that come to us as providers. So let's talk now about specifically childbirth and what happens when comes before or trauma happens during, and then what does it look like going forward? Because pregnancy, labor, delivery all share a lot of the same physical, psychological, and even sexual characteristics as different types of previous trauma, it can be a really difficult place to navigate, especially for survivors. But I would say it's terrifying for even those that don't have prior trauma. So what happens to them? Let's talk about triggers. Penny Simkin, I don't know if any of you are familiar with her. I see some heads nodding. She did some wonderful work on when survivors give birth, looking at specifically sexual assault survivors. But we can see these same triggers for different types of birth traumas as well as intrinsic triggers that impact the parts of the body that are reminiscent of prior trauma. Pain to nausea and vomiting and fluids that come out of them. Incredibly triggering for some. Kelly mentioned today, smells can be a real trigger. It might be body smells as well. Sounds are interesting too. I just worked with a patient recently we were talking about, do you have any fears about what you're going to sound like during labor? And she had a known history of childhood adversity. And she said, I don't know. Last time I didn't even know how to ask for help with pain. I didn't know how to verbalize it because as a child, she was never allowed to experience or show pain. So I like to say it was parented out of her. So she needed help in how she was going to sound. So it wasn't a trigger for her when she had pain. How could she self-advocate? I've had patients tell me, I cannot get nauseated. If I do, I will dissociate and I will not remember a thing. Horrible, and my PTSD will come back. Rather be sedated if that's what it took to treat their nausea at the expense of not necessarily remembering the birth so that they can still be functional afterwards. Listening to individuals, they all have a different trigger, perhaps, maybe not what we would think, but asking them, how can we help them to minimize that? Extrinsic triggers. This is everything in our environment. I don't know how else to put it. Everything in our environment can be terrifying for people. I exchanged the words extrinsic. My operating room. That's what would define it, right? It's terrifying for someone that's never been there before. The smells, the bright lights, all of this can be reminiscent. Even they would be restrained. Fighting very hard in our state to get rid of restraints. They're psychologically harmful and typically don't need to be used unless someone is at risk of hurting themselves or others. But even that thought that someone's going to be restrained in an operating room is terrifying. How about their lack of respect for privacy, right? Lack of feelings of having any control in an operating room setting. And we kind of expect them to want to be awake, to be able to manage that. It's really patient. Let's talk about birth trauma in particular. Trauma is not new. We could probably go back millennia and see early writings of the struggles that women have in childbirth. In 1957, in the Ladies' Home Journal, they published an article about the sources of suffering in childbirth. It's a fascinating article. If anyone wants it, let me know. I'll be happy to forward it. They received letters, physical letters back then, from around the country, from nurses and patients alike, talking about the sources of suffering. Now, more recently, we have more individuals sharing their stories publicly. We have these celebrities who've shared their birth trauma narratives. There's a book out there now called Invisible Labor. A reporter herself experienced severe pain during cesarean delivery and was dismissed. And she just wrote this book. It's very interesting. I just finished reading it. Seeing all this. Now, what's really interesting, though, is that these stories are separated by many decades. Yet, the sources of suffering that they talk about are the same. Powerlessness, loss of autonomy, no true informed consent, feelings of pain, being restrained, negative interactions with caregivers. Same narratives from 1957 to a few months ago, okay? We need to be thinking differently about how we are interacting with these individuals. So let's talk about the types of traumas or the types of complications that can create experience and lead to increased risk for postpartum PTSD. All of these have been studied. Fetal neonatal. I don't think anyone here would argue that when there is a loss, expected or not, it can be very traumatic. And there is often trauma also with it. But I'm here to say that 1 hour away from a baby, 1 hour with a baby in the NICU can be enough to increase someone's risk for postpartum PTSD. That kind of loss of that experience, we need to appreciate as providers. The loss of a child to what we call in our state CYS, I would assume you have something similar here, can increase the risk for suicide in the parents. So we need to think about that as well. Obstetric-related issues that have been studied. We know things like maternal hemorrhage can increase the risk for postpartum PTSD, but so can other severe medical illnesses. Pulmonary hypertension, preeclampsia, anything that would land somebody in the ICU, for example. Okay, emergency situations, even a stat C-section where everyone's physically okay, increase the risk for postpartum PTSD. Now, what I also like to mention is, I don't know what you call it here at your hospital. We call it a condition O. Do you have something similar here? Like a code pink, a rapid response? What do you call it?
Both rapid response team or code pink.
Pink. So I don't know how yours is run, but we still have 25 people, it seems like, that run. When you have this code called, all these people rush into a room. Well, that's been studied as well. And the response, where we're all focused on a task and no one's looking at the patient is overwhelmed in terror, can also lead to postpartum PTSD. So we might be saving somebody from one type of complication and also maybe contributing to another. I also point out, anesthesiologist, we also contribute to increase PTSD through some of our practices, which is inadequate anesthesia for surgical delivery or difficult epidural placement. We'll stick a needle in someone's back for an hour and we finally get it in and it works and we walk away and we do like this. Okay, we did it. But how often have we gone back to follow up with those patients about that experience? I will tell you, there is not one patient that wants to be poked for an hour. Ever, 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 ever. And it's terrifying to even the thought of a needle going in someone's back. So that can contribute also to postpartum PTSD. But what are the overarching number one contributors to postpartum PTSD above everything else? Helplessness, loss of control, minimal support, fear, negative subjective experience of childbirth. And I want to point out here too, because we're talking about complications and traumatic birth experiences. Not every complication equates to a traumatic birth. If a patient feels supported, safe at all times, trusts her teams, she has some control, but feels listened to, she might walk away from an unexpected hysterectomy, return twice to the operating room, time in the ICU, and still say, you know what, I'm doing okay, because I just saw that patient in my clinic not that long ago. I was amazed, and I said, well, I'm not going to create a problem when there isn't one. And we talked about, well, if something changes, let me know. But she was literally okay because she felt safe and supported. Whereas on the flip side, the absence of complications that we can see and identify does not mean that person wasn't. We have to ask the right questions. And I like the social worker that was up here talking who said, I sit and say, tell me about your birth. Open-ended, beautiful. Let somebody share their own narrative of what. Elicit a lot of information. Sources of birth trauma that we're hearing about. Complications that change the course, right? Switching gears midway through can create a traumatic experience. Now, these aren't necessarily associated with PTSD, but this makes for a negative birth experience. Unwanted routine interventions, disagreements, feeling coerced. You have to have that C-section or your baby's going to die. We can't always guarantee those endings and outcomes. We need to find better ways of communicating with patients so that they don't feel coerced into doing things. Loss of their own control over pain, for example, going to express themselves. They feel embarrassed when that happens. They want to maintain control not only of their environment, but of themselves too. Perceived poor treatment, lack of communication. If their partner doesn't support them, their doula, that can create a lot of stress and a negative experience. Mental defeat, unable to continue, feeling hopeless. That can be disappointment when they're supported and not necessarily guilt or defeat. It's very different. And then just the 180 degrees of what you expected and what you got. I know from a provider perspective, we see so much that we come into it, of course, with our own lens, but just trying to understand that someone really wanted an unmedicated birth at home and ended up with an induction of labor with every intervention and then a C-section. I think if we can hold space and tell them it's okay to feel whatever you feel about that, they are going to have to grieve that loss of experience. So let's talk about the after. Now that we've talked about trauma before, what does it look like with triggers? What do the traumatic events look like in our care? Afterwards. And this is not a complete list. Some people dissociate due to fear, due to pain. They don't remember their birth. Maybe it's a general anesthetic work and nobody looked at it early in labor. So it didn't necessarily need to be general. They don't remember the birth. They have to grieve that. Postpartum depression. Some of them are angry. They do not like us. They are not coming back for postpartum care, which is a really important time for us to assess physical and psychological complications. But they don't come back next time either. And then what do? We tend to judge. No prenatal care goes on the whiteboard. A lot of assumptions are made. Maybe she doesn't care. Why did this person? They didn't want to come back because of what happened last time. There is psychological harm impairing the maternal neonatal bond. So we see decreased rates of breastfeeding success after a traumatic birth. disruption in bonding, postpartum, psychologically ill. Baby, look at her baby, have anything to do with the baby, because the baby is the constant reminder. Negative parenting styles, attachment, offspring, increased risk for psychiatric and behavioral illness later on in the children. Now we're impacting generation. Let me say we, the circumstance. We're not doing anything deliberately. I don't want to misspeak here, but as a system, this is what is happening to them. Now, there's also disruption of the maternal fetal bond. So if there's unresolved traumatic stress in pregnancy, and it's coupled with depression, we see a 4-fold increased risk in preterm delivery. That's pretty significant. We also see increased rates of hypertensive disorders, IUGR as well, for these individuals. So could we identify them early in pregnancy? Could we help them with the stress, whatever that looks like, so that maybe we keep them pregnant longer, we keep them from having hypertensive crises? Would be nice. Maternal mental health. We've talked about depression, which everyone seems to be on board with, but that's not the only mental health complication. There is postpartum PTSD, which I would argue we have not screened appropriately for forever. And we're just learning enough about it now to know we need to be screening more for this so we can get them into the right care. There's also postpartum OCD, anxiety, and suicide ideation. Okay. People have negative alterations in pain. So what does this mean? It means, well, one, if they have mental health issues, different pain management regimen. So for those of you in the clinical space, if someone's saying I have 10 out of 10 pain, and you say, well, you had a straightforward delivery, it wasn't so straightforward in their minds. Maybe it was traumatic for them, but their pain thresholds might be different. We need different regimens, otherwise they end up with acute pain that's severe and then perhaps chronic pain afterwards. Okay. The anniversary of the birth trauma tends to fall typically on the child's birthday. Long association now with that birth. And it's a very, very difficult day for that individual unless she gets help and can heal this post-traumatic growth phase. Like what we heard Kelly talk about, she owns that picture with her at the baptism, right? Haunt her now. She owns it. She can tell her story. She's healed, right? But the people that don't heal have a really hard time on the birthday. Some choose never to get pregnant again. That's another impact of birth trauma. You'll see people that come in 7 years later. You'll say, it's an interesting gap. You know, maybe you start talking to them and then they tell you, I just couldn't do it for 7 years. They were too scared. Some will not come to the operating room. What does that look like? Well, I've had patients who share with me after the fact that they delivered their TOLAC, so vaginal birth after cesarean, at home. Because of what happened to them in the operating room, they refused to come back. Right? So that's not safe. We know that's not the best environment for them, but that could be a consequence of what's happening. And I think a really important thing to bring up today, although I do a separate session on this when I do full day trainings, and I don't have time today to talk about provider-based training or provider-based traumas, but we are impacted as well after every single traumatic birth. And we need opportunities to heal and to feel safe in these environments, know who we can turn to. I love the fact that you have a RISE program here, people that you can talk to if you have need. But you know, this trauma gives us PTSD symptoms as well, can lead to burnout, frustration, anger, even hostility. Okay, so morbidity or harm is not the only thing that comes out of traumatic birth. We also have death. I think one of the slides was up earlier today looking at the #1 cause of maternal mortality in our country, right? Mental health issues, right? So This is why we're here. This is why you are already engaged in some of this work, trauma-informed care, understanding trauma from the past, but how do we prevent current trauma? And what do we do with it so that individuals are not leaving us and committing suicide or dying from overdose or homicide? In Pennsylvania, 60% of our deaths at our last MMRC report were due to homicide, suicide, and overdose. Yesterday, I was in Kentucky, overdose. 2 months, and theirs was suicide. So we're seeing mental health conditions after that 6-week visit up to 1 year postpartum, what's contributing to death. And we have a very important role to play here in all of this. Anyone have any questions at the moment? Does anybody need to stand up, wiggle a little bit? I know this can get long, but all right. So let's talk a little bit about what is this concept? Like everyone's talking about trauma. I've been working in this space for over a decade, and honestly, I didn't know what I was doing was trauma-informed care for a long time. It was really what I thought of as holistic types of care, trying to understand the whole person, not just the physical person, respectful maternity care. I think of it as all one and the same, but trauma-informed care comes with a structure, which is helpful when you're trying to push it in a certain direction. Trauma-informed care in general, how we see people from what's wrong with you to what happened to you, right? That's a different shift. It's shifting from this is what we're going to do to you today to more of a, I'm going to pull up a chair. Let's sit down and talk to see what can we do together to come up with a mutually agreeable plan. Okay? Another one that I like to say in terms of the medical space, because we tend to judge and label patients a lot. We don't do it in a mean way, it just happens, but we might say this patient is difficult in this room, they're challenging. But if we could shift in how we see people from being problematic to symptomatic. Let me give you just a quick example. If you had a patient who was acting very strangely, saying things that were totally inappropriate, had body movements that were just out of the ordinary, and you walked out and you said, this person's just mean, they're nasty. And then a provider comes up and says, oh, by the way, their glucose is 35. Oh, is we're going to give them some sugar, and I'm going to walk away and I'm going to realize, oh, that's why they were that way. I don't take that personally. They needed glucose, right? They're diabetic. They had too much insulin this morning. The same with trauma. Lens to see these behaviors that they have as being symptomatic of previous trauma or what has just happened to them. It might allow us also to see them differently and not take so much of this home personally as well. This is one of the ways that trauma-informed care helps us in working with patients, and we tend to have better conversations. Trauma-informed care has 4 R's. This is where SAMHSA puts this out, substance abuse, mental health services. Realize that trauma is everywhere and that there are paths towards recovery. Recognize what it looks like, not just in your patient's family, ourselves. Respond. Take what you learn. Take what you're hearing from your patients. Create task forces within your hospitals. Change your policies based on the literature. What are we hearing? And then you actively resist re-traumatizing them. So if someone says to you, survivor of sexual trauma, I cannot be strapped down. And if you're in a hospital system that straps people down, you need to change that or think about ways that that does not happen for that patient. That's actively resisting re-traumatizing them. Is there another way to do it? Has expanded on those 4R principles. These are what we call the 6 pillars of trauma-informed care work. Starts with safety. That's psychological as well as physical safety. Can they develop trust? Is that the work you're already doing? By the way, I was very much in awe of this team up here today, but you could hear it with That same social worker stays with that patient. Our team from the high-risk unit goes with that patient to the emergency, to the operating room, right? Continuity, trust. Keep that patient with somebody that they trust. Peer support. Sometimes it's putting a patient in touch with someone who has lived experience, or it's a support group that helps them to process and move through it. Collaboration, not cooperation. There's a difference there. Cooperation would imply that you're doing what I tell you to do. Whereas collaboration is, okay, my doors are open, your doors are open. Let's figure this out together. You know your body better than I do. I tend to know the medicine better than others, right? Patients are doing a lot of Googling right now, but we tend to know the medicine better. That's why they come to us. They want us to be experts, but they understand themselves and their bodies better than we do. Empowerment, give them a choice. Individuals that get backed into a corner, especially survivors of trauma, do not function well when they feel trapped. Choice. Give them their voices. Don't dismiss them from where they're coming, right? Meeting them where they are, whatever their cultural, gender, ethnic, trauma background might be. Now, I like to put this slide up because I really want to emphasize that trauma-informed care is on a continuum. It's not something that you just leave here today and you're doing. Again, I've been in this over a decade, and I'm moving through this myself as well. So I work for an organization in Pennsylvania called HEAL PA, and our governor has appointed us as this task force in a variety of different aspects of our society to work towards making our state a trauma-informed state in education, law enforcement, child services, health. Physical and behavioral health is my action team. So what I've learned through all these trauma experts is that we are in this continuum. So what does that mean? Become trauma aware. This is today. This is the lecture. You are getting your awareness about all those, right? Where does it come from? How common is it? What does it look like? Start to think about things a little differently, perhaps. Then you become sensitive. And I would say your group is already in this space. This is where you start to see things from someone else's perspective, not judge. Just want to roll our eyes when patients ask for something. We're truly trying to see it from their perspective, and we're starting to work towards those 6 pillars. When you are trauma informed, you're really taking all of that information, you're changing your policies and your practices, and you're using that on every single patient. Okay, but your system is also changing. You get support from the leadership. You're starting to look at these practices to see what works. You're getting feedback from your patients. And then once you reach the end with a healing-centered, trauma-responsive space or system, that's where you're not only doing this on a regularly consistent basis, but you're also, what do they call it? Proactive adaptability. In other words, you're looking at it constantly, collecting some data, metrics. What can you do better? Kind of a system would be wonderful. And I'm very perceptive at my own hospital, but you might have a sign like this here. I don't know. But we have a sign as you enter the hospital that says something to the effect of, we don't tolerate abusive language, gun violence, et cetera, and there's a long list. And someday I would love to see that sign changed. There is no need for gun violence, strong language, et cetera, because we're trauma informed. We get you, right? There needs to be a shift. And that's kind of my goal when I think of a system, is to shift it to that. We don't need that if people feel safe and trust in their institutions. So a couple slides on why. Why is this even important? Why am I standing here? Well, you already saw some of the consequences of a traumatic birth. I put those up already. But let me share a couple of other statistics that are, I don't know, they're concerning to me. And these are supported over and over again. About 1/5 to 1/3 of all females will be the victims of childhood sexual trauma by the age of 18. That's a lot. If you extrapolate that to childbearing age and you think, how many of these individuals are coming to us with this history? It's a lot. About a third of all female veterans self-report a history of military sexual violence. That's in active duty. When you look at new data that looks at their lifetime exposure to sexual violence, it's over 60%. Now, I don't know if you have a veteran here. Do you have military bases here in Nebraska? I don't know if it's, but if they've been in the military, perhaps it's worth having a conversation about their past. Experience severe physical violence from an intimate partner in their lifetime. Up to 44% of women, depending on the circumstance, will report their births as traumatic. That's a huge number. And of course, on the high end of this are those that experience early pregnancy loss and ectopic. But even on the low end, we're looking at 25 to 30%. Awful lot of people to be saying their births were traumatic. So not always joyous in the land of obstetrics. Now, we know that because we work in it, but patients don't know that. All they hear is what's out there, and their friends are talking. The friends had a great birth, and what they read on social media, which then sets them up for a different expectation as well. Pregnant teenagers have a mean ACE score of 5.1 over 10. So you know what that means. In my mind, pregnant teenagers have a history of trauma until proven otherwise, which means using trauma-informed practices, which have no side effects, by the way, can be helpful for all of them. All of those 6 pillars can be very helpful. 9% meet criteria for preeclampsia or for PTSD when they meet an obstetric provider. 9%. So let's put that number in perspective. Preeclampsia has an incidence somewhere between 7 and 9%. Experts in the audience can correct me if I'm wrong, but I still think it's roughly in there. Yet if I asked all of the providers here to tell me about preeclampsia, how do we treat it? What are the risks? What do we do? Everyone would know. To a different disease process that has same kind of morbidity and mortality, maybe worse, we don't know enough about it. We don't know how to interact as providers. Like, there are people out there, the mental health specialists know what to do, but I'm talking about those of us in the space. Many of them have never disclosed, which adds another element to this. They live with either chronic traumatic stress, they might have disclosed to one person and they were met with disbelief or blaming, and so they've never talked about it again. So we don't know who they are. We have to use maybe those behaviors or some of those other things in the chart to help identify these individuals. And another reason why we need it, I'm just putting this up one more time, people are dying from trauma and health and mental health related conditions. This is why this is important. Some other costs. Trauma-informed care work. Well, people with anxiety and depression end up in the OR more often for C-section. 12-fold increased risk, especially for those with adult on. Survivors, especially females, often avoid preventative care, which is a great opportunity to intervene early in other disease processes. The trauma survivors in general utilize the ERs more frequently. New cases of PTSD from sexual assault, it's been studied, it's very studied. It costs us billions to our society every year. Now, at some point, I think someone could repeat this study with new cases of PTSD after childbirth. And I can't even imagine, because we're now looking at intergenerational transmission of trauma. And what does that cost over time to the children as well, and family members? I've already talked about the impact on the fetus, the growth restriction, preterm delivery. Any neonatologists here or people that work in the NICU in the audience? It's expensive to be in the NICU. So there's preterm delivery at 26 weeks. It's about $40,000 a week to keep a baby in the NICU that early. Very, very expensive. We have exposure to illicit substances. These patients are less likely to receive prenatal care. So that also causes more harm to the unborn child. We talked about breastfeeding issues, bonding issues. Oxytocin deficiency can be transferred as well. If someone has depression and oxytocin deficiency, that can go through to the baby. I just saw a recent article. I put the link up there, or the reference. They're starting to look at the fetal brain. They can do this with imaging in utero, and they're showing structural development for those that have significant stress in pregnancy. Not sure exactly what the implications are yet, but it's interesting. Now we're just going to talk briefly about how we do it. And I want to make sure we're staying on time here. What do I have as time, Mary? What do I have to end? What's my hard stop?
About 20 minutes, 15 to.
In order to be able to engage in this, I think it's important to realize we have to talk to patients about what they need from us. So great qualitative studies have come out looking at what patients see, what they need to prevent re-traumatization. Trust, communication. Many people would love to disclose what their experience was, but they don't want to have to tell every provider at every change of shift every day. Patients live with us for weeks. So we have to figure out a better way, because telling their story can be akin to reliving it, and that's very stressful for them. Like to know what's happening. They own their bodies. We don't. We need to ask permission before we do things. But they would like some clear explanation about what is the plan, what's happening today, who's working on me today, or who's with me. I always like to throw this out. I don't know if you're a teaching hospital here or not. We have residents, medical students where I am. Sometimes it's not appropriate. Trainees or any trainees with survivors of trauma. Sometimes, though, the medical student or the nursing student is their lifeline. They develop a wonderful rapport, and that person should be there with them. But this is not the circumstance where we want to be overwhelming them with a ton of trainees standing there watching, especially for rape survivors. It's more harmful than it is beneficial for anyone. Privacy. They might want to wear their own clothing. Some people might want an elective C-section based on their trauma, even if it's their first baby, and we need to think about that. Some women with different types of trauma are okay with males, some are not. And if we have an all-male staff, right, can we establish trust early on with certain individuals so they do feel comfortable? Some women with a history of sexual abuse or histories of mastectomies, reasons may choose not to breastfeed. Some choose not to breastfeed after a traumatic hemorrhage the first time, and it was so stressful for them to try to breastfeed because they were anemic, they didn't have support, stress and depression, and irritability and lack of sleep, that they refused to do it the subsequent time. We should offer them counseling. If they want to try it again, great. How can we support? But for some, breastfeeding is not going to be beneficial. Breastfeeding may be more psychologically harmful for them. So take that on a case-by-case basis. But I know hospital systems have, the pendulum is swung over here. It's the best. But just, think about where these patients are coming from. It might not be the best in the overall big. Put some of these principles, like the 4 R's, and I just kind of overthrow in general. What does this mean for obstetric? So if we realize that a large number of our patients are going to come to us with histories of trauma, and to realize that it could negatively impact their care. Okay, that's step 1. Recognize risk factors, identify those that you think are vulnerable early. Who can they talk to ahead of time? What can we do to prepare them for potential triggers? There is a group in Colorado. Some of my colleagues are getting ready to do a study where individuals that we know are high risk are going to have to go to the operating room, like those with accretas or previas. They are going to go through and get tours of the operating room ahead of time. And they've done a pilot study, and they've shown that they've decreased anxiety scores before and after with this process. Take my patients through the operating room if they need that as part of their planning. We do it in a safe way, give them a chance to desensitize, familiarize themselves. But these are some of the things that we might want to consider to help people prepare for what's coming, right? What do we do to recognize when acute stress is happening? That takes also recognizing when a traumatic event. Better job of asking those questions. Tell me about your birth. Are we screening for traumatic birth? That's like the $1,000,000 question. I get that everywhere. There is no consistent way to do that yet. People are trying to find that, but we don't have it yet. And then resist re-traumatization. These are just a couple of things that I had published before, primarily for an anesthesia population. But I think it's important to look at some of these. Early identification of high-risk populations. What kind of pain management expectations do they have? What's the role of the significant other? What are we doing for panic? Do these individuals have panic already? What do they do to help calm themselves? And what are the safe anxiolytics to give? Because we're balancing an unmedicated mom who might panic or dissociate, in addition to maybe having a physiologic negative response, versus a small amount of exposure to the neonate. And we do have very safe medications that can help balance those two. Minimum number of providers, keeping a room calm and quiet. Can we do it? These circumstances, but I'm always the optimist. I think we can always be looking for better ways of creating a safer space for individuals. Looking at, are you starting a surgery before the block's working? See what you can do to slow things down. Make sure we are testing things with evidence-based methods. Some empowerment language to think about. Based approaches for patients. Right? You did this. Thank you for sharing. This had to be really difficult for you. You were very brave with what you shared with me. It's not your fault. You've heard some of that already this morning. This has had an impact on your life. I put up there, I'm so sorry that happened. Some people are worried about that word sorry as if it implies guilt. If that's a problem, say I'm saddened. I'm really saddened that that happened. A really difficult thing for you. And I'm just going to go through some of those quickly with you too, the key points here. Use your instincts when you're working with individuals. Clinicians, trust your instincts. What are people saying? If it doesn't seem right, there might be something more to it. What are they doing? Are they on their phones? Are they trembling? Is their knee bouncing? Are they not making eye contact with you? Emotional clues. How are they feeling? I heard the doc this morning saying, we want to walk in that room after it all happened and be, hey, how are you today? Man, you went through something yesterday. You tried to die on us. Man, it was crazy, right? If you're walking in with that, the patient might feel like they're supposed to feel that way, right? It's supposed to be happy or joyful. Back and then just try to take in their emotions in the moment. How are they feeling? Use that to help with that collaborative approach. And physical clues too might tell you if they're having an acute stress response. If they're hyperventilating, their lips are purple because they're so scared and they're clamped down with their peripheral vasculature. I've seen all of it. Terror. That is sheer terror. Pay attention to these clues. They're going to help people with a simple Lives mnemonic. This has been studied with physicians interacting with those with domestic violence. I think it's very useful and helpful. It's easy to remember. You're saving lives. Listen, inquire, validate, enhance safety and support. So I'll just go through those quickly. Listening, open-ended questions. Tell me about your birth, right? To be in front of the computer the whole time. Distractions, sit down. One simple thing you can do, get rid of the hierarchy, sit down. Chances are you probably could use it anyway in your busy workday. Of that, and be eye to eye with them when you're talking to them and try not to interrupt. I know it's hard. We have busy schedules. Try not to interrupt. There'll be the right time to do that. inquire without us showing how we feel about the circumstance. Again, like that, whoo, she tried to die on us yesterday. No. We need to hold hold space with them, however they're feeling. If I'm talking to a patient, she said, Dr. Vogel, it was almost 5 minutes, but it was horrible. And I'll say, did it work? Yeah, it worked. I'm looking at a patient that might have a BMI of 90, right? As an anesthesiologist, I want to say, wow, 5 minutes, that's fantastic. Their perspective, 5 minutes of their lives. So we need to just be careful about how we show that. We don't want to appear shocked, but we want to inquire gently. Do you feel comfortable sharing some things about that experience so that we can figure out how to make you feel better or how to help you this time, etc. Validation is really important in our work because there are two layers of trauma that can happen. One is the traumatic event itself and all that it comes with. Layer, which I would almost argue is worse, it's the worst atrocity, is when providers dismiss that level of trauma that they just experienced, right? You'll be fine. I mean, everybody goes through that. You should be happy. Everybody's physically healthy. You should be fine. We need to validate their emotional experience, whatever that is. Anything it just says, however you're feeling is valid. You went through something very difficult, right? That's what validation is. And sometimes and we can't always fix it because trauma is messy. Providers were often uncomfortable with a box or cure or fix. Trauma is messy. Sometimes the best we can do is sit and support and hold space. If someone comes in with a loss, you can't fix that, but you can sit with them. You can tell them they're not going to be alone and that you're going to support them. Safety. Find out, what do they need from you? Our nurse from the floor, I loved all the stuff that she advocates for. What will make you feel safe here? Do you want to have your daughters come in? Do you want to do their hair? Do you want to go for a walk? Right? Emotional safety as well as physical safety here. Who do they need? What do they need? Deviate from your plan. And there's nothing a patient hates more than having that plan changed every single day when a new provider comes on. That adds to layers of trauma for them because they feel like they have absolutely no control over what's happening. Support follow-up. It sounds like you all have really good mental health providers or support in your system. Use them. When you feel something's not right, don't lose these patients to follow up. Make charts, put them on whiteboards, find a way that people can continue to reach out and touch base with them to make sure they're okay. Trauma symptoms don't always appear immediately. In fact, they can appear even up to a year later. For some, it's 20 years later when they're triggered again by something because they've suppressed for so long. So frequent check-ins with these individuals might be important. Just for the sake of time, because I do want to come back to those two vignettes, I'm just going to quickly breeze through these, but tell you there are still a lot of barriers to incorporating trauma-informed practices into time and money and support from the administration and the leadership. Those are the big three. Everywhere I go, the same barriers exist. And in order for us to make change, we have to attack all of those as well so that providers can get the education that they need. Additionally, not just on the provider end, but there could be patient characteristics or demographics that might make it difficult for people to share and engage in this. They might feel like their history is not relevant. Some of them find it's very difficult to express their history. Mental health pathologies there, socioeconomic factors, cultural differences, even teenagers might not want to. Right? So it might be challenging for a variety of reasons, just from on the patient side as well as from our side. So again, thinking about how can we make change, we have to think about our own barriers, and you may have your own unique ones here as well. What is our role in all of this? And you can think about this in a variety of ways. Primary prevention, we're talking about trauma disrupting care. This is the latest thing on the trauma-informed care. construct. Really, it's about prevention. How can we prevent trauma from ever occurring? Taking what we learn and changing our practices. That's primary prevention. Secondary prevention is after a traumatic birth, how do we intervene in a time-sensitive manner so we prevent the development of severe symptoms? Screening, identification, getting them into the right hands. Tertiary prevention is once they have PTSD. Next, that's where we're talking about our mental health therapists, EMDR, cognitive behavioral therapy, group therapy. There are a lot of different things that we offer our patients once that happens. So before we come back to those vignettes, I always like to say of individuals, yes, I'm asking for you to think about these 4 R's, the 6 pillars, seeing things from a different lens. But I'm also asking you to be curious. I wouldn't be here today if I didn't have that little bit of curiosity about someone else's story. Because we see people often for a glimpse, or maybe 6 weeks if they happen to stay with us that long, and we get to know them. But typically it's for a short period of time. That period of time, it's often a very stressful time for them. And so we might not see them at their best or what they would consider their best, but very stressful time. And there's a lot of judgment that goes on in the healthcare space. But if we can learn to pull that curtain back a little bit and see there's a lot behind there, that might help us to engage in a little more collaborative approach, understanding where they've come from. We might then get better engagement in care, more trust, and then better outcomes. Close on what I did or what we did as a team. Remember, we left off the patient refusing everything, very sick with preeclampsia. So I went in with her obstetrician, just the 2 of us. I sat down on a chair lower than where she was and explained some pain management options with her. She was in pain, she was in labor. And I said I would do her epidural myself as the boss anesthesiologist. I said I would use an ultrasound, no trainees, because I didn't want there to be any other trauma for her. And she agreed because she was in a lot of pain. So I said, okay, that worked. Creating some trust. That was very straightforward. Once she was comfortable, again, sat down lower than where she was. And I said, sounds like you really don't want to go to that operating room. Did something bad happen there before? And she shared that she'd had 2 prior orthopedic procedures where she remembered them strapping her arms down and putting a big face mask on her face. Now the doors are opening. I know she has a history of abuse of some type. She has medical-based trauma in there, and she's terrified. So then I say, it's something called normalization. I say, well, it's terrifying for most people. What I do with my patients, we don't use any straps here. You want, and you can keep your significant other with you. I use low doses of anti-anxiety medicines if we need them. We keep you warm. And I just went through a list. Normal. She didn't even have to feel like she was different. Do all these things. And she said to me, you can do that? I said, yeah, we can do that. So that then opened the doors and we created a plan. And ultimately, she chose the cesarean delivery because she understood her physical risk. She had done everything right so far to grow this baby. She just didn't know how to make the decision. She couldn't think straight. She was having acute stress. That operating room, it was amazing. And I don't think I ever got as many hugs as I did after that for what she was so grateful for what we helped her to do. We didn't need any of the consultants, although I kept the ethics committee around just in case. But we didn't need the attorneys. We helped her to understand her situation by us understanding her past. I see how that works, and it helped us. I felt really good that I served her well, and she felt great. And it also opened the doors later for us to have a conversation and for me to slide some referrals in for her for future therapy to address her childhood trauma. So we had all sorts of healing going on there. This case, where she was dismissed from having pain during cesarean delivery, she came to see me in my clinic and first of all received a safe space to talk about it where she was believed and validated. because everyone had really dismissed her to this point. That went a long way in healing, just to start with validation. Post-traumatic stress, which she was high on the screening tools, very, very high with her symptom severity. Put her in the right hands. I think that's what she ended up doing after that experience, and working with an individual therapist, also doing Project Lullaby, which is a music therapy type of program that we offer. And I also talked to her and gave her hope. This is the other thing, just to plant the seed that she wanted more children, but she knew she'd be terrified to ever come back. But I started to talk to her what delivery could look like in the future. And that left her, with this bigger picture of, we can do this differently next time. And so that all helps with healing. And then for some patients, I can't remember if this was one, allowing them to write their narratives so I can take providers, lets them know that their story, just like, is being used to help make change in a bigger system. Therapeutic. So that's all I have, guys. Take questions at this point.
I just have one quick question. You kind of answered what I was going to ask is, how do you get this off the ground? If we're at this point where we're becoming educated, and in our world in the prenatal center, we see a lot of moms, prior to potential trauma experiences, we see whether that was a pregnancy loss, and I always felt that we fail, that we get these patients for a glimpse, just a moment in time, and then they're gone. And maybe we haven't addressed things the way we should have. And then they show back up, and it's like all of these unresolved issues. Now we're trying to get them resolved for the pregnancy. By then, we're ready to kind of building it. Because to me, I can't imagine utilize that type of service.
I would say think big, start small. The way I did it was to start with my already existing high-risk OB anesthesia clinic. So there was structure. So you might think about, you have some high-risk players here in your system, whether those are MFMs. You also have some amazing social workers that are working in this space. To think about, how could you expand that a little bit, to start to bring in those with increased risk for psychological harm, right? That's where I'd start. And then think about, the training. How do you make sure someone is trained? I mean, I'm happy to share what because there isn't a fellowship in this yet. There is no official credentialing in those of us that work in this space all have certain things. Hill PA has established certain structures for what would be necessary if you were going to go and do a training. Those could be useful as parameters to say, okay, whoever we want to work in this clinic, we want to make sure that you know this. And a lot of that is in this talk today as well. Set up a little bit more training. Then you have to educate, because it's a collaborative process. Like, I can't work in a silo in my clinic. I could create all these plans with patients, but if my providers don't buy in, really traumatized, right? We have this plan. So it's bringing in every specialty. So a lot of collaborative meetings, maybe some lectures to say, how do you feel? Like, as an anesthesiology group, how do you feel about bringing a significant other in for spinal, if that's needed for psychological safety? How do you feel about this? We want your opinion. Bring them to the table. The NICU teams, can you not do footprints right away? Get that baby over to mom. Or can you, if the baby needs oxygen, can you still put the baby on mom with an extra long tubing to the anesthesia circuit in the OR, for example? Like, every team has a role to play, but I think it's asking them and incorporating them in it. That's what's really important. Like, physicians, providers, we don't want to be told what to do. We want to be part of the planning and the solution. And that's what I did a lot, is to keep going back and saying, this is what I'm thinking, but what do you think? Is this possible? What are you willing to collaborate on? And then you can start to build actual protocols maybe for your system. But again, start small and build. Yeah, like I said, it took me a while to get a grant, and then the infrastructure, if you use an electronic health record, referrals, you can utilize a behavioral health line. That's My Clinic Lives in Behavioral Health, which offers the office and the scheduling. So yeah, it's a great question. I don't see nearly enough in my clinic because there's only me. So my step right now is I'm trying to train someone else because it's too busy. There is a clinic in Oregon run by Kathy Jorda. She's an obstetrician and she does hers a little differently. She sets aside an extra hour visit for patients for trauma-informed care. She bills outside of the bundle for that. And if you want to talk to her as an obstetrician, how she's doing it, I'm happy to share her contact.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.